talk about the autonomic nervous system, dysautonomia, and its relationship to cranial cervical instability. I mean, is there a relationship? Is there a connection between dysautonomia and the brainstem? So that's what we're going to ask and hopefully answer today. Now, the autonomic nervous system controls all those things we don't have to think about. Cerebral circulation, cardiac function, baroreceptors and blood pressure, kidney blood flow, gastrointestinal function, pulmonary secretions, airway resistance, circulation to the skin, and all of those things that are necessary to maintain homeostatic functioning in the environment without having to think about it. So the autonomic nervous system is comprised of two parts: the sympathetic, fight or flight responses, and the parasympathetic, which is let's have a beer, eat something, and just laze around and digest. So on the right is the sympathetic system. It arises in the posterolateral hypothalamus, and the fibers percolate through the brain, through the reticular formation, and then they travel down the spinal cord in the intermediolateral column of the spinal cord, posterolaterally. And they come out of the cord between T1 and L2. And they form paired efferents bilaterally that form ganglia and then autonomic nerve tracts that run up and down, up to the brain and the neck, and down to the heart, the GI system, bowel and bladder function. And they're paired efferents, but then there's also some unpaired, the superior and inferior mesenteric and the celiac plexus. So that's the sympathetic. Now on the right side are the parasympathetic fibers. And that's composed of cranial fibers and also lumbar fibers. Cranial and sacral fibers. Now the cranial are comprised of the cranial nerve 3, which causes constriction of the pupil, and cranial nerve 5, with which nerves to the sphenopalatine and oda ganglia run, and more importantly, cranial nerves 9, the glossopharyngeal nerve, important in swallowing and sensation in the upper throat, and other things that we'll learn about. And the vagus nerve, which is of extreme importance, which carries fibers to the heart to slow it down, to the lungs to increase mucus secretion, to the bowel to increase secretion of different hormones, and we'll study that in a minute, increased digestion. And then the sacral component of the parasympathetics, which arises in the end of the spinal cord, the conus medullaris, the sacral nerves S2, S3, S4, which supply the bowel from the splenic flexure down, the descending colon next to the spleen, from there down to the rectum, and bowel and bladder and sexual function. So this is the cranial sacral parasympathetics then, and you see the sacral parasympathetic nerves coming out of the distal portion of the spinal cord. Now, how does the autonomic nervous system affect circulation in the brain? And most circulation in the brain is by an intrinsic mechanism. If you have high blood pressure, the brain automatically closes the arteries to minimize or to dampen that high blood pressure. If the metabolic demand is high, there's a lot of glucose consumption, then the arteries will open up to allow more blood in. And if there's a high acidity or low pH, the blood vessels will open. That's the intrinsic mechanism. But the extrinsic are the sympathetics and parasympathetics. The sympathetics via the carotid artery cause vasoconstriction of the arteries to the forebrain, and the sympathetics via the vertebrobasilar complex cause constriction to the hindbrain arteries. and the parasympathetics do the opposite, open them up. Now, there's a very important nucleus in the brain called the Locus Coeruleus, and this manufactures norepinephrine. And if you've ever had a fright and you feel like adrenalinized in a second, that's the Locus Coeruleus dispersing norepinephrine throughout your entire brain. So this nucleus affects arousal, attention, memory, cognitive control, emotions, and stress. And it gets input from the hypothalamus, from the medial prefrontal cortex, from the environment via the nucleus gigantocellularis, and from other parts of the brain. And it projects really to all parts of the brain, the cortex, especially the prefrontal cortex, the hippocampus, the cerebellum, and even the spinal cord. Now, dysautonomia involving the locus coeruleus can cause depression, panic disorder, anxiety, may contribute to Parkinson's and Alzheimer's, and post-traumatic stress disorder and ADHD. How does the autonomic nervous system affect cardiac function? Now, most blood flow through the heart is controlled by the Starling mechanism to balance left heart output with right heart output. So the more blood coming into the left ventricle, the fibers expand and then pump out more and increase the cardiac output. That's the Starling mechanism. So blood flow can vary from 5 to 13 liters per minute. But the effect of the sympathetics and some input from the parasympathetics can increase the cardiac output to 20 liters per minute. The sympathetics exit at T5-6, and then they travel along the coronary arteries and influence the alpha-1 and beta-1 receptors and the sinoatrial and the atrioventricular nodes to speed up the heart and increase the inotropism and chronotropism, increase the cardiac output. Now the vagus descends, the fibers enter along the atrioventricular groove and to the same sinoatrial and atrioventricular nodes. They increase the potassium on the sarcolemma around the muscle, and that hyperpolarizes the membrane, making it less sensitive and slowing down the heart rate. Now, how do we control blood pressure? There's stretch-sensitive baroreceptors on the aortic arch that ascend along the vagus nerve, and the baroreceptors and the carotids, which ascend the glossopharyngeal nerve to the nucleus solitarius and the medulla oblongata, the lower part of the brainstem. So if there's an increase in blood pressure, these baroreceptors will start firing up to the nucleus solitarius. The nucleus solitarius will send messages to the ventrolateral or the caudal ventrolateral thalamus, which sends inhibitory fibers to the rostral ventrolateral thalamus, which then decreases the sympathetic output and lowers the blood pressure. And the opposite happens if there's a low blood pressure. So now also, if there's a decreased blood pressure, the nucleus solitarius will send messages down via the intermediolateral or up to the thalamus, and then down through the sympathetic system, through the spinal cord, out the spinal cord through the splanchnic nerves, which come out in the lower thoracic levels. These go to the aortico-renal ganglia, and from there they go to the kidneys, where fibers stimulate the beta-1 receptors on what are called the juxtaglomerular cells. And this increases the secretion of renin, which starts holding onto sodium and increasing the blood volume. So we got these balancing systems to maintain blood pressure. Now, how about the airways? The influence of the autonomic nervous system comes from the nucleus ambiguus, which is also involved in swallowing and some talking, through the vagus nerve, which innervates receptors in the trachea and bronchi called the M1 receptors, then the M2 receptor inhibitory feedbacks, and then M3 cells which secrete mucus and cause bronchoconstriction. In the vagus, there are also A delta fibers, which are very small and myelinated fibers that are sensitive to smoke, histamine, and serotonin, and C fibers, which are pain fibers, which are going back up the vagus nerve. And they, noxious stimuli like smoke, activate the C fibers, which then triggers parasympathetic activity, including constriction of the airway to minimize the entry of the noxious substance, increased mucus gland secretion, vasodilation, increased vascular permeability, leaky blood vessels, and increased mucociliary activity. So, how about the GI system? The cranial nerves 7 and 9 stimulate the salivary glands to secrete mucus. The vagus nerve, cranial nerve 10, stimulates gastric acid and pepsin secretion in the stomach, and secretion by the pancreas of trypsin, amylase, and lipase to digest carbohydrates and protein and fat. And they stimulate secretion of cholecystokinin to contract the gallbladder. Along with the sacral nerve cells, they secrete transmitters and peptides to control the intrinsic nerve system of the bowel, and that's the Meissner submucosal bodies, the Auerbach myenteric plexus, the deep muscular Cajal fibers, and this stimulates bowel motility. So here we see the vagus innervating the bowel to the splenic flexure, and then the sacral parasympathetics innervating everything from above the spleen down to the rectum. And the sympathetic nerves maintain continence by contraction of the internal sphincter, rectal incontinence. The sympathetics also decrease blood flow to the bowel, but they don't affect motility. So too much sympathetic activity, you're not going to get good absorption. Another view of the intense innervation of the bowel. This is also called the enteric nervous system. The autonomic disorders of the bowel include dysphagia, gastric reflux, gastroparesis, malabsorption, bloating, constipation, irritable bowel syndrome, colitis, and incontinence. The autonomic nervous system controls the pupillary responses, sweating, and temperature control, blood flow to the skin, absence of which or poor abnormal blood flow can cause a Raynaud's-like phenomenon and can cause regional pain syndromes. And we're going to talk more about syncope today. The Framingham study showed that men have 3% incidence of suffering from at least one episode of syncope. Women, a 3.5 incidence of syncope. And this is due to activation either of a cardioinhibitory vasodepressive reflex or, in the case of EDS, orthostatic hypotension. In other cases, acute decrease in cardiac output, increase in resistance. Now we know that syncope is probably comorbid with Chiari malformation. There have been a few reports of that. But most, the cause of most syncope and the hereditary connective tissue disorders is partial orthostatic tachycardia syndrome, which occurs in about 3/4 of the EDS population. And it's the most disabling symptom of dysautonomia. Now, Gate and Lowe have found that with POTS there's a high resting sympathetic tone, but a very poor response and inadequate vasoconstriction in response to hypotension. So on the left you see a patient, the heart rate upon standing, and there's an increase in heart rate of 30 points above normal, and that would assign a diagnosis of partial orthostatic tachycardia. And on the right is a case of neurally mediated hypotension, and this patient on a tilt table was stable, and then after 10 minutes suddenly dropped the pressure to a very low level. And this is the loss of the vaguely mediated cardiac response to hypotension. But primarily these issues are the result of blood pooling in the lower extremities and not leaving enough blood in the vascular system for the heart to pump and maintain normal blood pressure. So causes of dysautonomia, we're talking about a system that spans from the brain to the spinal cord to the peripheral nerves and all the way to the skin. So there are many causes of autonomic impairment. It's stratified, involves the peripheral and the sympathetic nervous system peripherally. There are many causes of dysautonomia, including hereditary conditions, autoimmune conditions, fibromyalgia, chronic fatigue syndrome, asphyxiation, poisoning, injuries to the peripheral nerve system, Lyme's, TB botulism. Mitochondrial disorders have a big overlap with dysautonomia. Degenerative conditions like Parkinson's disease. And we're going to be talking more about trauma, the chronic trauma that is inherent in the hypermobility connective tissue disorders and brainstem deformity conditions. So our hypothesis then today is that biomechanical deformity of the cervical medullary junction alters autonomic activity. So what are the main brainstem nuclei implicated in causation of dysautonomia? And the dorsal motor nucleus is the main one, the nucleus solitarius, and the nucleus ambiguus, and they're all in the medulla, and they're right where a lot of this deformative stress occurs. I don't know if the locus coeruleus, which is a little higher up, is affected by deformative stresses. Now we see biomechanical deformity with Chiari and basal invagination and so on. We also see dynamic deformity as a result of cranial cervical instability, the skull sliding back and forth, and iatrogenic deformity. Anyway, I'm going to show you those. So here with the Chiari, you can see the cerebellum compressing the brainstem. You can see how that might cause a problem. And in Brockmeyer's series of 206 cases, 20% of those patients, so that should be 106 patients, 20% had a kyphotic clival-axial angle and or basal invagination, which caused brainstem biomechanical deformity. We can see pannus or inflammatory changes behind the odontoid. You can see the end of that arrow, and that thickening of that membrane, the tectorial membrane, can cause compression of the brainstem. Platybasia is a flattening of the floor of the cranium, and it introduces a kink in the brainstem, and you can see that kink there. This basal invagination was from one of my patients with rheumatoid arthritis, and the odontoid had gradually herniated up through the skull base and was pushing on the pons. Atlas assimilation is where C1 remains fused to the skull, and that can cause compression on the brainstem and instability. And here's a case of a child who had a very generous suboccipital craniectomy for Chiari malformation, but this craniectomy also destabilized her enough so that the skull slides forward and causes some compression of the brainstem. There are about 50 hereditary connective tissue disorders, and even though EDS was described 100 years ago, the spinal and neurological manifestations have only recently, in the last 20 years, been understood, and we published on that in 2017. So why does deformation of the central nervous system alter neurological function. And this is how I became interested in this problem in 1993 in London, doing a research project on cadavers, patients who had died of basal invagination, compression of the brainstem. And we found these interesting silver staining spheroids called axon retraction balls. And these are due to accumulation of axoplasm, and they result from biomechanical stretching and deformity. So a few years later, no one believed me back in 1993, but a few years later, Pavlicek, Maxwell, and others showed that if you stretch neurons, that there's a collapse of the cytotextural architecture of the axons, and the neurofilament are the microtubules which are responsible for transporting axoplasm down the axon, stop working, so you get a pileup of axoplasm, and that's what it looks like, these axon retraction balls. And Satman showed if you stretch a mouse optic nerve just 20%, that you get these axon retraction balls forming. And Wolf showed that if you stretch a nerve, you get this massive influx of calcium, shown here in yellow, with its deleterious consequences. And Arendine showed that stretching a nerve was an epigenetic stimulus, and it triggered increased expression, increased manufacture. The gene would be switched on to start making more N-methyl D-aspartate, which makes neurons more sensitive, better for learning, but also more sensitive to injury. And this stretching can also trigger mitochondrial dysfunction and apoptosis. Shai showed that if you stretch a nerve, you decrease the conduction. You can see the tall white column, that's normal conduction. Now, if you stretch it moderately, you see that the amplitude of that conduction decreases. With severe stretching, there's a severe decrease in that amplitude. And if you stretch quickly, a fast strain, then the decrease in amplitude and the size of that neuronal firing is greatly decreased. So does brainstem compression cause injury to the brainstem? Yes, and it alters nuclear activity within the brainstem. And we showed in 93, 10 patients with basal invagination. And these patients all had sleep apnea, but with a transoral odontodectomy, removing the odontoid and a reduction, stabilization, the sleep apnea improved in all of those patients. And we published that in 1994. Now, subsequently, we developed a finite element analysis model, which is a mathematical model to predict the stresses and strains in the brainstem and spinal cord in these patients. And it looked at a combination of stretching and deformity. And then it provided these pictures that color-coded for the degree of strain. And so we're looking at the kyphotic flexion deformity in clival-axial kyphosis. And on the left, that picture is normal with zero strain, but you can see with increased bending at the brainstem level, there's a kinking in the cord, and that causes a stretching, and that stretch causes a high strain. And so we published in 2010 a series of 10 patients where we performed traction and straightening of the brainstem and fusion stabilization. Here's one of the cases. This is an 11-year-old boy who was in the emergency room 2 or 3 times a week with what his parents described as respiratory arrest, but by the time he got there, every time he'd be breathing again. But he had a whole host of dysautonomic findings and syncope and this absent loss of breathing. And you can see that the brainstem is very deformed, and there's a Chiari there. And when we did the mathematical finite element analysis, we found extremely high stresses in the order of 50 newtons per square centimeter. And after we performed the reduction, stabilization, fusion, the stresses decreased to 5 to 10. And when we compared the ASIA score, that's sensory motor function, and the Karnofsky, which is performance, and the physical and mental components of quality of life, these correlated very closely with the stresses that were developed in the nucleus solitarius and the dorsal motor nucleus. And we achieved significance even with a small number of patients. Now, earlier this year, we published a 5-year follow-up of 20 patients who'd undergone craniocervical fusion for craniocervical instability with Chiari malformation. 20 patients, all the data was sent through a nurse. I did the exams, and Dr. Kobe did the radiology. We stressed the importance of dynamic imaging. The image on the left looks tolerably normal, but with flexion, now you can see the odontoid pushing back into the brainstem, and that's a clear case of basilar invagination and ventral brainstem compression. We also looked at the Harris method, which is the measurement of the skull sliding forward. And we looked at the Grab-Oaks methodology, which is another measure of ventral brainstem compression. And we looked at C1-2 angulation. If the angle between C1 and C2 was more than 41 degrees, that's considered a subluxation. The indications for fusion were severe headache, cervical medullary syndrome, neurologic deficits referable to the craniocervical junction, and congruent radiological findings. And we wanted at least 2 of these radiological findings. So the surgery, the patient was positioned prone, and we exposed the back of the head and the spine. We performed a suboccipital craniectomy and then placed those screws and the hardware to stabilize it. These patients, the fusion was performed with their own rib, so everyone had rib pain for several years. We did the usual intraoperative reduction. Here's the clival axial angle reduced to greater than 140 degrees. We want the mandible to axial interval about 10 to 20 millimeters, and we want the orbital axial angle. This is the gaze angle. This is, where their head is pointed. And if they're very tall, we would have them looking down slightly. If they're short, we'd have them looking up slightly, but all around 95 to 105 degrees. So prior to surgery, they all had the cervical medullary symptom, all the symptoms associated with craniocervical instability and basilar invagination. Well, let's look at, after surgery, to varying degrees of enthusiasm, everyone said they would repeat the surgery given the same circumstances. All but 2 patients said the surgery improved their symptoms. 2 had so many other morbidities that they did not enjoy any improvement. The fusion rate was 100% using their own rib, and the headache went from average before surgery in red of 8 to an average of about 4.7, I think. Now, what were the dysautonomic symptoms that improved after surgery? Syncope, 85.7%, headaches, balance problems, dizziness. Now, the hands and feet turning cold, only a third of those patients got better. Fatigue, a third of patients. Gastroesophageal reflux, a third of patients. Nocturia, which is micturition, urinary problems, a quarter of patients. Irritable bowel syndrome, 1 in 5 patients. In Karnofsky, so some of the dysautonomia symptoms improved with the craniocervical surgery, but a lot did not. Karnofsky performance scale, 0 is dead, 100 is normal. You need 80 to have fairly normal functioning. And the performance scale here, before surgery was pink, and it was around 55, and after surgery it was 78. So 12 of the 20 patients were either back at school working or at home helping with the children. And these improvements correlated with improvements in the clival-axial angle. The clival-axial angle is a sort of a surrogate for brainstem deformity. So we thought recently, talking with Peter Rowe and Claire, that we'd like to design a study to look more closely at this dysautonomia problem and look at patients with atlantoaxial instability. Does stabilizing C1, C2 improve dysautonomia? So these questionnaires just went out a few weeks ago, and slightly less than half of them are back. And maybe the more enthusiastic responses, the early ones might be better, so the data may be a little skewed toward the better results, I'm not sure. But these are preliminary results. We know that C1-2 instability appears to be not uncommon in the EDS population. It's also common in rheumatoid arthritis, 25%, Down syndrome, ankylosing spondylitis, myxedema, hyperparathyroidism, skeletal dysplasias. And dysautonomia in atlantoaxial instability has been described. So we had 20 patients, and we sent out questionnaires, and I performed the exam. Indications for surgery, headache and neck pain greater than 7. Now, with C1, C2, most of these patients, almost all of them had syncope or pre-syncope. Almost all of them had occipital neuralgia or occipital neuralgia-like headaches. Almost all had visual changes, or tunnel vision, and numbness in the hands that might come and go, and or feet. And on neurologic exam, they had hypoesthesia to pinprick, hyperreflexia, increased reflexes, and tenderness over C1, C2, and atlantoaxial instability by CT scan. So we would put the patients in there, rotate the head to the left and right. Here's a C1 rotated, pointing to the right there. That's angled 85 degrees from the front, and the C2 is angled 40 degrees. So the difference there is 45 degrees, and that exceeds the pathological threshold of 41 degrees. So that constitutes atlantoaxial instability. And on the top left there, you can see near subluxation of that C1 facet on the C2 facet, a little more turning, and that would be dislocated. And that could cause pressure compression of the spinal cord. And on the top right is a 3D CT showing the loss of facet overlap. Lower left, you see the screw stabilization, and on the right, a 3D CT showing fusion stabilization. So the symptoms prior to surgery were legion, a lot of, well, as you know, really everyone complained about 20 things. But importantly, this is what got better. The syncope severity, 100% of patients reported improvement in severity. Of pre-syncope severity, 2/3 reported improvement. Chronic regional pain syndrome, reflex sympathetic dystrophy, a few patients, severity decreased. Exercise intolerance improved. Orthostatic hypotension frequency and severity lessened. Vertigo frequency improved 3/4 of the time. Headache. Lightheadedness frequency, 75% got better. Anxiety frequency and severity, 71% improved. Lightheadedness severity, 2/3 improved. And these numbers might be a little bit small, but they're all just to show the significance value. And so we saw a lot of, even for this small number of patients, we saw a lot of statistical significance on those symptoms. So let's go beyond. So in looking back, I would still choose to have this should be C1, C2 fusion surgery, and all of the early respondents strongly agreed. Having this surgery improve my symptoms All but one of these patients agreed, one disagreed. The headache was preoperatively in red, was severe, and decreased to mild, moderate postoperatively. And same with the neck pain. Dizziness diminished from moderate and severe to mild and moderate. Average lightheadedness decreased from severe lightheadedness to mild. Average syncope went from many cases severe to none. Pre-syncope, as you can see, decreased there. Orthostatic hypotension decreased from severe to none or mild. Now, there are a few instruments that measure orthostatic function. So orthostatic grading scale here, before surgery, the frequency of orthostatic symptoms upon standing, preoperatively in red, you can see were usually always present upon standing. And after surgery, you can see that the frequency has diminished significantly. Interference with daily activities. Prior to surgery, there was moderate to severe interference with normal daily activities in red, and then after surgery, most patients reported mild and moderate, or no interference or mild interference, with only a few experiencing some severe interference of daily activities. So the SF-36 showed statistical significance in terms of the ability to perform vigorous activities, walking more than a mile, and the global impression of change. One patient reported no change or worse. The others were moderate, better, or a great deal better. Kanofsky performance improved significantly. Before surgery in red, was averaged about 65. After surgery, average 75. So we saw significant improvements in dysautonomic symptoms after correction of deformity and stabilization, in syncope and pre-syncope, in the chronic regional pain syndrome and reflex sympathetic dystrophy severity, exercise intolerance severity, orthostatic hypotension frequency and severity, vertigo, headache, lightheadedness, anxiety frequency and severity, and sleep apnea and night awakening. So the autonomic nervous system is anatomically ubiquitous, complex, stratified. Dysautonomia, however, occurs frequently with the hereditary connective tissue disorders. It is strongly associated with conditions of instability and deformity of the brainstem and upper spinal cord. And that association, however, does not prove causality. It's an association only. It shows some improvement after reduction of deformity and stabilization. And I'd like to thank my co-workers, and thank you for your attention.